Hello, my name is Dr. Mark Johnson, and my goal for this continuing medical education event is to discuss fetoscopic laser therapy for twin-to-twin transfusion syndrome. We all recognize that twin-to-twin transfusion syndrome is one of the most common complications in monochorionic or identical twin pregnancies and result in about 17 to 18% of all perinatal mortality that occurs in twins. If untreated, greater than stage 2 and above, mortality is actually 80 to 100% in the past, and even with successful intervention, mortality and morbidity, even with intrauterine therapy, has been quite high. The issue with monochorionic placentas or identical twin placentas is they have two major features. One is that, like all children, they never share anything equally, and therefore these twins do not share their overall placental mass equally, such that one twin inevitably has a much smaller portion of the placenta than its co-twin. The other key feature is that there are anastomoses or vascular communications across the two sides of the placenta that link the fetuses and therein link the fates long-term during pregnancy of the two fetuses. We know that these vascular communications can be of three types. There are some that are artery-to-artery connections, communicating the artery from the one smaller fetus to the larger. There can be venous-to-venous connections, and then there can be unidirectional communications as shown at the top of this placenta, where an umbilical artery from one twin goes into the placenta, and then the oxygenated and nutriated blood comes back through the vein to the other fetus. So Mark Denbow in 2000 did a very interesting study that opened the window to further our understanding of what's actually going on in these placentas. He looked at 71 monochorionic diamniotic identical twin pregnancies and did vascular injection studies. And what he found was that development of twin-twin transfusion syndrome, or TTTS, was associated with multiple unidirectional arterial to venous communications between the twins and an absence of arterial to arterial anastomoses. He noted that the risk of developing twin-twin transfusion increased significantly with a greater proportion of donor to recipient arterial to venous connections, and that the presence of an arterial to arterial anastomosis, or AA anastomosis, significantly decreased the risk for twin-twin transfusion. They postulated that these AA anastomoses functioned as equilibrators for the unidirectional anastomoses. They postulated that the larger the size and the number of donor to recipient connections, the greater the likelihood of volume transfer from the donor to recipient, and therefore the greater the impact of the AA communications were that are actually sensitive to fluctuation in blood pressure within the placenta. So they postulated that the donor to recipient volume transfer through the unidirectional AV connections resulted in a fall in donor blood pressure because of volume loss that resulted in an increase in artery to artery flow from the recipient to the donor side. So this increased AA flow into the donor placental territory resulted in a recipient artery to donor vein type perfusion, leading to a compensatory, what they called rescue transfusion to the donor that then prevents development of twin-twin transfusion syndrome. So even though there are a number of donor to recipient artery to vein anastomoses, the volume transfer through these communications can be offset by the presence of an artery-to-artery communication that flows towards the decreasing blood pressure of the donor side. So what we have learned is that actually the more communications there are between the fetuses, the lower the risk for developing a complication in that pregnancy. The fewer the communications, the absence of artery-to-artery anastomoses, and the higher the number of donor artery to recipient vein anastomoses, are significant predispositions to the development of twin-twin transfusion syndrome. So when we look at the placenta, the smaller baby that will become the donor generally has a significant smaller portion of the overall placental mass and therefore starts to develop some signs of evolving placental insufficiency because it has less tissue to facilitate oxygenation and pick up nutrients from its limited placental volume. So these fetuses compensate for this by changing blood flow throughout their bodies such that there is a compensatory increase in blood flow to their heart and their brains, the infamous cephalization of blood flow to protect these two vital structures. They do this physiologically by releasing vasoactive substances that cause constriction of the vascular beds in the organs such as the kidneys and the bowel, and also decreases perfusion in the extremities such that the majority of blood volume is therefore directed to the heart and brain to improve survival and development of these key organ systems. However, these vasoactive substances also get transmitted to the placenta and cause constriction within the vascular bed of the placenta, leading to the increased placental resistance that we see later in more severe forms of twin-twin transfusion syndrome. So it is postulated that this increase in resistance on the what will now become the donor side of the placenta increases resistance such that blood flow preferentially crosses the vascular equator, and the donor fetus now starts to access placental mass on the recipient side of the vascular equator as shown by the green arrows. This strategy does allow it to send blood into a lower resistant portion of the placenta, but does not guarantee that all of that blood will return to the donor side, as sometimes the blood, part of the blood volume will go to the recipient as well as return through the vein-to-vein communications to the donor fetus. So because of this shift in the vascular equator and because of the presence of a number of donor artery to recipient vein and absence of significant size or number artery to artery communications, there will be a net loss in blood volume from the donor side and increased blood volume to the recipient side. And this physiologically results in a recipient that now is hypertensive, is hypervolemic, and needs to deal with this increased blood volume in its circulation. This results in increased cardiac output and hyperperfusion of organs such as the kidneys, resulting in increased urine production or a state of polyuria. This results in polyhydramnios that leads to an increased risk for premature rupture of membranes or onset of very early preterm labor because of the massive distension of the uterus. But this increased hypertension and hypervolemia status results in a progressive hypertrophic cardiomyopathy in the recipient twin that, if left unchecked, can lead to cardiac failure, high drops, and intrauterine fetal death. The donor twin remains anemic, hypovolemic, therefore it has ongoing hypotension. It cephalizes blood flow to the heart and brain, becoming more and more oliguric. It becomes significantly growth restricted because of chronic hypoxia and decreased nutrition from the placenta, eventually becoming anhydramnionic, or the infamous stuck twin, and suffers chronic hypoxia and growth restriction and is at risk for dying in utero because of placental insufficiency. A key factor here is that you don't want either twin to die because they are connected by these vascular communications such that the death of either the recipient or the donor will change the pressure gradients between these two sides of the placenta, such that when one twin dies, the other twin will then pump its blood volume into that portion of the placenta and into the body of the dead fetus, experiencing a significant drop in blood pressure and blood volume that can result either in death or severe neurologic injury because of stroke-like phenomenon. So when we talk about twin-twin, we need to talk in terms of severity so that we can look at progression of the disease as well as the success of possible interventions. And Ruben Quintero back in 1997 came up with a scoring system for twin-twin transfusion and staged it into 5 different categories. Stage 1 was early disease and is defined as the recipient having polyhydramnios with a deepest vertical pocket of amniotic fluid of greater than 8 centimeters, the donor having oligohydramnios with a deepest vertical pocket of less than 2 centimeters. Stage 2 was defined as findings from stage 1 plus the additional finding of a very small bladder in the donor that did not fill and empty or cycle normally. Stage 3 he then defined as stage 2 plus the additional findings of Doppler flow abnormalities and the donor fetus preferentially showing increased resistance to blood flow as reflected by decreasing SD ratios in the umbilical artery. Stage 4 was defined as high drops, usually in the recipient twin, but potentially also in the donor twin in the process of dying because of its placental insufficiency. And stage 5 was defined as a pregnancy where one of the twins had died. But what Ruben actually did very successfully was describe the physiologic changes that occur in twin-twin transfusion that we now recognize that we did not understand at the time of his scoring system, such that stage 1 actually represents the initial stages of volume transfer from the donor to the recipient side, leading to progressive oligohydramnios because of cephalization in the donor twin, and the polyuria from hyperperfusion of the kidneys in the recipient twin. Stage 2 represents the cephalization that's progressive in the donor twin such that it becomes more anuric and therefore does not produce sufficient urine for the bladder to cycle. Stage 3 represents the increasing placental resistance because of the vasoactive substances produced in higher and higher volumes in the donor fetus. And stage 4 represents the progressive hypertrophic cardiomyopathy and cardiac failure that occurs in the recipient twin. So interesting that his initial staging system actually very closely reflects the progressive physiologic changes that occur over time with twin-twin transfusion syndrome. Over the last perhaps decade, our way of looking at twin-twin transfusion has significantly changed, and we now look at it as 2 sharp edges to a double-edged sword with 2 key physiologic things going on. One major component is alterations in amniotic fluid hydrodynamics, and the other major physiologic problem is the hypertensive placentopathy that occurs. So let's start with stage 1, which is basically just amniotic fluid discordance, where there's polyhydramnios in the recipient twin and oligohydramnios in the donor twin. Much controversy revolves around the appropriate therapy for stage 1, but several small case series suggest that only about 30 to 35% of these cases actually progress to stage 2 or higher, that about 28 to 30% just remain in stage 1 throughout the whole pregnancy and have favorable outcomes, but quite interestingly, 40% of them actually go away or completely resolve. Because of this, many people are reluctant to more aggressively treat stage 1 twin-twin transfusion, and basically management at this point revolves around amnioreduction for severe polyhydramnios because of the risk for cervical change and preterm labor or premature rupture of membranes. So prior to selective laser therapy, amnioreduction was the mainstay of therapy for twin-twin transfusion. And basically, all we thought we were doing was reducing volume within the uterus to prevent the physiologic changes that would trigger preterm labor. But actually it turns out we were doing much, much more than that, and we were actually changing the physiologic environment for both fetuses. Many of us who do amnio reductions for severe polyhydramnios, one of the first things you notice is as you pull that stylet out, the fluid goes shooting up over your shoulder because of the high pressure within the uterine cavity. Also, if you look at the placentas are fairly thin and look highly compressed, again because of the high pressures in the uterine cavity. So Nick Fisk and his group back in 1989 and 90s studied this, and they looked at the relationship between amniotic fluid pressure and fetal oxygenation and pH. And what they found, as shown in the dark circles on the upper graph, is that when you enter the uterine cavity of in a case with severe polyhydramnios, the pressures within the uterus are markedly elevated, sometimes 2 to 3-fold higher than in normal cases where amniocentesis is performed for diagnostic reasons. So with amnioreduction, you see this drop as reflected by the black arrows from this high pressure situation down into normal pressure levels within the uterine cavity. But they also performed chordocentesis before and after the amnioreductions, and they showed a direct linear correlation between intrauterine pressure and the degree of hypoxia in the fetuses, noting that as the amniotic fluid pressure decreased, the amount of oxygenation significantly increased and the acidemia significantly decreased, associated with the degree of pressure change. So amnioreduction actually improves oxygenation in the fetuses, and the key to that is probably secondary to compression of blood flow through the compression of the placenta and impact on blood flow through the placenta. And shortly after this, or just prior to Nick's studies, Bauer was looking at uterine artery impedance indices and qualitative blood flow to and within the uterus before and after amnioreductions in the presence of severe polyhydramnios. And what they found is that amnioreduction seemed to improve blood flow to the uterus, blood flow to the placenta. They demonstrated it reduces vascular resistance within the placental bed, meaning more blood can flow, improves overall blood delivery to both fetuses, and particularly to the donor fetus, who many times has a velamentous cord insertion such that the severe polyhydramnios can directly compress the vessels crossing from the velamentous cord insertion to the placental edge. So amnioreduction actually improves blood flow to both fetuses, improves placental function, increases oxygenation, and intuitively increases nutrition to both fetuses. And ours and other groups' observations was that after aggressive amnioreduction, a decade or two ago, we did notice improved growth and development in the smaller donor fetuses, restoration of urine production with reappearance of the bladder, and improved overall physiologic state. But the increased blood pressure and volume in the recipient twin causes its own group of physiologic changes and therefore risks and threats to the recipient twin fetus. Again, not only is there net volume changes that results in hypertension and hypervolemia, but along with that, the donor fetus is sending lots of little gifts to the recipient twin that include all of these vasoactive factors that get into the recipient twin system and causes vasoconstriction out in the periphery, but is also transferring cytokines and growth factors to the recipient twin that can impact on normal heart growth and development. And when we look at what we have called hypertensive placentalopathy, it results in a progressive hypertrophic cardiomyopathy, and the progressive part of this is key to understand that these changes occur over time. We initially thought it was just only volume stress, but we have found that it's not always directly related to volume stress, but there is increasing afterload pathology because of activation of the renin-angiotensin system in the recipient twin that increases vascular resistance in the extremities and in other organ systems of the body, significantly increasing afterload, thereby increasing pressures within the left side of the heart, whereas on the right side of the fetal heart, it's the high volume that results in increased pressures in the right ventricle that we have measured to as high as 3 times higher than normal, that leads to the progressive dilatation of the right ventricle, progressive hypertrophy of the ventricular wall, increasing pressures that then can lead to tricuspid regurgitation as the blood flows into the right ventricle. The ventricle contracts, but the pressures are so high that there now is regurgitant flow back into the right atrium. Over time, this high volume, high pressure flow across the pulmonary valve can actually injure that valve, resulting in impaired growth and development of that valve, pulmonary insufficiency, and over time can result in severe pulmonary atresia, very similar to congenital pulmonary valve atresia that requires surgical intervention after birth, or can result in overall cardiac dysfunction and development of cardiac failure, high drops, and fetal death. We were very intrigued about the physiologic changes that we saw in these recipient twins, and so we spent many years studying these changes as they progressed through the different stages of twin-twin transfusion. And what we developed was a cardiovascular scoring system for these changes that we observed. We looked at the different components of ventricular function, the AV valvular function, venous Doppler characteristics, great vessel analysis of the pulmonary artery and aorta. And what we found is that there was a very characteristic progressive series of changes that eventually resulted in cardiac failure and risk for in utero death. In this whole scoring system, the only thing we really look at is umbilical artery Dopplers, and out of the total score of 20 points, the poor donor only gets 2 of those points to contribute to the scoring system. The scoring system was then divided in mild changes of 0 to 4 points, moderate changes of 5 to 9 points, moderate to severe or more significant progressive hypertrophic cardiomyopathy reflected by scores of 10 to 14, and really significantly impaired cardiac function in the severe range with scores of 15 to 20. But this scoring system was not designed to be a prognosis determinant. This score was only designed to allow us to study the natural physiologic changes that occur in twin-twin transfusion, and perhaps offer us a tool to look at physiologic changes, hopefully improvement, that result from in utero intervention for this disease. So what do we do when we have a fetus that's stage 2 or above? We know that once a fetus reaches stage 2, it becomes a progressive disease that will progress at an unpredictable rate, but will progress to stage 3, potentially stage 4, in worst case scenario, stage 5. So in cases of stage 2 or greater, what we have learned is that we need to interrupt the vascular connections between the two fetuses, prevent the net transfer of volume, restore volume and pressure to the donor fetus, prevent transmission of these vasoactive substances, growth factors, and cytokines to the recipient twin, basically separate the two fetuses, and then hope for the best that they can have a positive physiologic response. And the way that we do that is using fetoscopic selective laser photocoagulation. If you look at the left upper image of this slide, you'll notice that we're looking at the vascular equator. The blue vessels represent umbilical arteries from the donor side, and you can see that there is a small branch that branches off that lower artery into the placenta, but that the pink vessel bringing oxygenated and nutriated blood is going back to the other side of the placenta to the recipient twin. In the lower image, again, you can see a donor artery with deoxygenated blue blood going into the placenta, and oxygenated pink blood is coming out and going to the contralateral recipient side. And so the focus of the therapy is to go in and identify each of these communications, and then using a laser fiber photocoagulate them to essentially cauterize or spot weld them shut. This is a video of a case. In the upper portion of the image, you can see the artery coming from the donor fetus with the blue blood. You can see this first connection down there between an artery and the recipient vein. We're now mapping this artery down, down, down until it connects into a large vein from the recipient twin. And you can see that we're identifying the communications between the donor side and the recipient side, and using a 600 nanometer diode laser fiber, we're able to photocoagulate these communications. It's important to appreciate from this film clip that there's a lot of movement, because the placenta in this case is posterior and is picking up the pulsations of the underlying aorta, maternal aorta, and some of these connections are probably somewhere in the neighborhood of perhaps 1/10 of a millimeter. So it's actually quite fine and precision work. As you can see, we're picking off these small hair-like communications here between the donor and the recipient. And it takes time, patience, and takes a lot of experience to not only identify these communications, but successfully photocoagulate them. But you can see from this film clip that by doing so, successfully interrupts the exchange of blood volume from the donor to recipient side, as well as interrupts the transfer of vasoactive substances, and hopefully changes the pathophysiology of this disorder. So shortly after the publication of the famous Eurofetus randomized trial between amnioreduction and selective laser photocoagulation that showed an improved outcome using laser, studies started to appear in the literature looking at improvements in survival. And this study that came out in 2006 from the group in Hamburg showed a significant improvement in overall survival of over 71%, with equal distribution of survival between donor and recipient twins, a significant increase in both twin survival compared to amnioreduction, and now at least one single twin survival approaching 84%, with a mean age of delivery of over 34 weeks, whereas with amnioreduction the average age of delivery is around 29 weeks, thereby decreasing the degree of prematurity in these kids and the prematurity-related morbidity and mortality. As studies continued to accumulate, they were sub-analyzed as to stage, and again, there was demonstration of significant overall improvement of survival across all stages of disease, even in stage 4, when one of the twins was significantly hydropic. They were still able to get 50% of kids were both 50% of cases where both twins survived, and at least one twin surviving despite the presence of a hydropic fetus in 70% of cases. So significant improvement in overall survival, even at the most severe end of the spectrum. And then larger volume centers such as ours continue to show that experience plays a factor. And looking at our results from 2005 to 2013, which also reflects somewhat of our learning curve, we are now able to achieve 88% overall survivals, with 78% of both twins surviving following laser, and now 93 to 94% of cases with at least one twin surviving, and a mean age of delivery between 34 and 35 weeks. And this seems to be about the highest numbers that have been reported, because we all have to remember that there are complications of laser for twin-twin transfusion. Sometimes following laser we lose the donor fetus because they just do not have enough placental volume to survive, and so donor loss rates are somewhere in the neighborhood of 6 to 7%. The other major complication is membrane separations, because in the presence of severe polyhydramnios when you are inserting a 3 to 4 millimeter fetoscopic sheath through the membranes. It is not uncommon for high pressure fluid within the amniotic space to leak across the amnion and accumulate between the amnion and chorion, resulting in amniotic membrane separations. Following the procedure, there is now a defect in that amniotic membrane, and the degree of membrane separation can progressively increase, resulting in larger or even global membrane separations that then predispose the pregnancy to premature rupture of membranes, possibility of ascending chorioamnionitis, onset of preterm labor that results in a not insignificant complication rate, resulting in loss of both fetuses or severe prematurity. But perhaps one of the greatest benefits of selective laser therapy is the decrease in long-term neurologic morbidity in twin-twin transfusion syndrome. In small case series that have been published looking at outcomes with amnioreduction, people were able to document that anywhere from 40 to 55% of kids who survived twin-twin transfusion after amnioreduction had some degree of long-term neurologic deficits, major deficits ranging between 20 and 26%, or minor learning disabilities ranging from 15 to 30%. But following selective laser therapy, this long-term neurologic morbidity is significantly decreased. And in the first long-term outcome study, again by the Hamburg group in 2003, they showed that major morbidity was present in only 22% of cases and 11%, and minor morbidity in 11%, so an overall 22% neurologic delays. And a follow-up from them in 2006 where they doubled the number of cases, showing the impact of learning curve on the technique. They demonstrated that now major neurologic deficits were present in only 6% of kids following laser and only 7% with minor learning disabilities, a significant and major improvement over amnioreduction studies in the past. But one of the most impressive things that we found using our cardiovascular scoring system is that the recipient twin has an amazing ability to heal its heart and to reverse the physiologic consequences of twin-twin transfusion after laser therapy. And our routine is to look at the cardiac score before surgery, the day before surgery, and then we always follow up these cases in 7 to 10 days to again basically look for physiologic response, to look for complications such as membrane separation or developing worsening Doppler findings in the donor twin. And what we have found is that in the vast majority of cases, the cardiovascular score significantly decreases in the recipient twin as early as 1 week after therapy. Many cases going from very severe hypertrophic cardiomyopathy down into the mild to moderately severe range in 1 week's time. We also were able to identify a few cases where improvement was not demonstrated, as shown by the red lines in this graph, and these are cases that require ongoing echocardiographic surveillance because these are children that are at risk for developing significant right outflow tract obstruction at the level of the pulmonary valve that may require balloon valvuloplasty after birth. And so in cases that do not improve within the first week, we usually have them come back within 2 or 3 weeks later. And if we continue to see signs of worsening right outflow tract obstruction, we arrange for them to deliver in a tertiary care center that has pediatric cardiac interventionalists that can evaluate and treat the right outflow tract obstruction if necessary. So in conclusion, I think the take-home messages are that untreated early onset severe twin-twin transfusion syndrome has a very high infant mortality and a very poor neurologic intact survival if untreated. Aggressive amnioreduction therapy initially showed improved gestational age at delivery to 29 to 30 weeks, which is still significant premature, and showed significant long-term prematurity-related complication. And survivals for at least one twin did reach into the 60 to 65% range, both twins surviving in perhaps 40 to 45% cases, but with major neurodevelopmental and cognitive morbidity in about 25% or higher of survivors. Selective laser therapy decreases prematurity morbidity because of a more advanced gestational age of delivery between 34 and 35 weeks, and significantly improves survivals of at least one twin into the 90 and now approaching 95% range, both twins surviving now into the 75 to 80% range, with significantly less major neurodevelopmental and cognitive morbidity and only 5 to 7% of survivors. So I hope you enjoyed this online CME activity. I hope you appreciate the interesting pathophysiology of this complication of identical twins and the success that laser intervention offers, not only in survival, not only in decreasing prematurity-related complications, but improving long-term survivals and neurodevelopmental survivals.